When lawmakers introduce state-sanctioned medical assistance in dying, they often promise a system sealed by impenetrable legal boundaries. These protections are designed to keep the program restricted to the terminally ill, used only as a last resort. In the United States, advocates point to mandatory waiting periods as a primary safeguard. The logic is that 15 days gives a terminal patient a final window to reflect, preventing impulsive decisions during a temporary crisis. However, those statutory boundaries are already moving. California recently shortened that mandatory 15-day reflection period to just 48 hours for certain patients. In Oregon and Vermont, federal lawsuits have successfully eliminated residency requirements. This allows individuals to travel across state lines specifically to obtain lethal prescriptions that are illegal in their home jurisdictions. These legal shifts in Vermont and Oregon represent an intentional transition. The original set of protections serves as a starting point for a steady process of legislative expansion. To see where this trajectory leads, we have to look at the empirical data from Canada. Since federal legalization in June 2016, Health Canada has officially documented over 76,000 completed assisted deaths. Headlines frequently cite a larger milestone, 100,000. This number is a near-term projection. At the current annual growth rate of 15 to 30%, the country will reach that cumulative threshold by late 2025 or early 2026. This data table illustrates an exponential rise. In just 8 years, annual deaths climbed from roughly 1,000 to over 16,000 in 2024. Mapped against total mortality, medical assistance in dying now accounts for 5.1% of all annual deaths in Canada. Pro-expansion advocacy groups often dismiss these figures as sensationalized, but the verified baseline tells a different story. 1 out of every 20 deaths in the country is now state-sanctioned, a statistic with no precedent in modern public health. Canada began with the same restrictions currently seen in the U.S. In 2016, Bill C-14 limited the program to cases where natural death was reasonably foreseeable, meaning patients with terminal conditions like late-stage cancer or organ failure. 3 years later, a lower court ruled that restricting the program to the terminal was unconstitutional discrimination against the disabled. The federal government declined to appeal the ruling to the Supreme Court. Parliament responded with Bill C-7 in 2021. This legislation fundamentally changed the legal framework of Canadian healthcare by creating 2 distinct pathways for assisted death. This new framework included Track 2. It explicitly permits a state-assisted death for individuals with chronic pain, physical disabilities, or progressive conditions whose natural deaths are not foreseeable. At the same time, Bill C-7 removed the mandatory 10-day reflection period for terminal patients. In many cases, an individual can be assessed and receive a lethal injection that same day. The statutory framework now facilitates death for individuals who could otherwise live for decades, representing a significant shift from the program's original focus on end-of-life care. This expansion into non-terminal cases reveals a disturbing clinical trend. Many individuals choosing the Track 2 pathway cite the failure of the public safety net as a primary driver for their decision. In high-cost urban centers like Toronto and Vancouver, disability support payments average between $1,100 and $1,400 a month. These figures fall significantly below the poverty line, making accessible housing and specialized home care virtually impossible to afford. Case evidence highlights the human cost of these shortages. Amir Farsood sought a state-assisted death because he feared becoming homeless after his disability support proved inadequate for his housing costs. Other documented cases include Christine Gauthier, a disabled veteran who requested a wheelchair ramp for her home. The state's response was an offer to provide medical assistance in dying. Roger Foley recorded hospital workers offering him an assisted death, while simultaneously denying him the home care he needed to manage his degenerative disorder. For many of Canada's most vulnerable citizens, lethal injection is provided more quickly and more reliably than the basic social support they need to survive. These clinical shifts are now crossing into the American context. U.S. jurisdictions are actively adopting policies that echo Canada's reliance on a broader range of medical practitioners to execute the program. This statutory audit shows that states are expanding prescribing authority for lethal medication beyond licensed doctors, granting it to nurse practitioners and physician assistants. Shorter waiting periods and expanded prescribing authority integrate assisted death into the standard management of chronic illness. This systemic transition happens through incrementalism, subtle judicial rulings and statutory tweaks that gradually add up to a significant policy shift. These changes in American law are following a documented blueprint. The erosion of safeguards is a deliberate roadmap toward the same outcomes across the border. As Canada approaches the 100,000 cumulative death threshold in the next 2 years, the scale of this policy experiment is becoming clear. The initial promises of strict terminal-only guardrails have been set aside in favor of a much broader application of the law. Canada now serves as a proof of concept for state-funded death as a standardized medical intervention for suffering and poverty. To visualize the scale, imagine 100,000 lives ending through these state-sanctioned programs. Canada's trajectory is a warning to some, but for the lawmakers pushing similar changes in the United States, it is the blueprint they are already following.